coronary multi-slice CT is ethically acceptable for screening purposes with flying personnel. Okay, let's look at the 60% of you think that it's ethically not acceptable. Major Beekmann of the Royal Netherlands Air Force Center of Men in Aviation is going to talk to you about screening for coronary heart disease in aviators of the Royal Netherlands Air Force, and we're going to see what happens afterwards.
Good afternoon, ladies and gentlemen. Thank you for introducing me. As you can see, I'm just a simple pilot who became a flight surgeon, and this subject is also supported by the two cardiologists that we work with in Central Military Hospital in Utrecht, Rink Rinks and Hendrik Natu. I'm going to talk to you the next 2 hours on coronary CT and hope to keep you awake. Next slide, please. So we've already had this. So to keep you awake, let's first talk about dogs. As you can see, people who have a dog tend to look like their dog after a while. Now, I hope, if you have a dog, I hope you don't look like your dog that way. The question is, do our pilots start to look like our aircraft? Because in Holland we have the F-16 already since 1979, and it's still the same aircraft actually on the outside. And it's getting quite old. If you can have the next slide, please. And it's a fly-by-wire aircraft, and 9G aircraft, you get some chafing, so it's not very good for the wires. So if the aircraft is doing that bad and our pilots look like the aircraft, are they doing that bad as well? Because we are getting some older pilots also. So if we look at our pilots, next slide please. This is one of our older pilots. I wonder how his coronaries look like. I would like to know. So we have a screening, and we actually started doing that only very recently. Because, we had a couple of problems with that. Luckily, our aircraft had a midlife update. Next slide, please. And which makes it beautiful again. And the next step is to make our coronaries beautiful also for the pilots. Next slide, please. So we had a couple of pilots with problems with coronaries and actually died because of it within a couple of years. So the leadership in our Air Force said, this is a big problem, we got to do something about it. Find me a solution. And our cardiologist came up at that time, years ago, with the exercise ECG. So we use the exercise ECG for screening for coronary artery disease. Now if we look at just one case that we had, a colleague of mine, F-16 pilot, male, 41 years old, asymptomatic, flying around happily, came by our center for his annual medical exam. Look at his cardiovascular risk factors: smoking for 25 years, that's not too good. His BMI a little bit overweight, not too bad. Cholesterol high, normal. His father died at age 63 because of a heart attack. He did exercise, not too much. He did exercise also in the bar a lot. His blood pressure was 137/87, so nothing special there. Resting ECG completely normal. He came in happily, he was expecting to fly the next day again. Then we did his exercise ECG, and that turned out to be positive. We saw ST segment depression for 1 to 2 millimeters, but he had no symptoms at all. So we sent him to the cardiologist, who did an MSCT, and then saw that the LAD was completely obstructed, and gave him a bypass. Next slide, please. Another case that I saw was a boom operator, male, 51 years old, asymptomatic again, cardiovascular risk factors, look at that, non-smoking, BMI not too bad for a 51-year-old, cholesterol low, normal, negative family history, regular exercise, he played tennis quite a lot, all his life, blood pressure it looks like it's a bit high, but actually if you look closer and you try to measure it again a couple of times, it's quite normal. Resting ECG normal. He did an exercise ECG and he did pretty good. He came very far, a good exercise. And afterward he had a vasovagal reaction, which is not abnormal. We see that more often, where people, when they stop too early or too abruptly, get a vasovagal reaction. You have him laying down on the ground and his feet up a little bit, and after 10 minutes everybody thought that he recovered. At that time he was still connected to the leads, still no change, absolutely normal. I even called the cardiologist to look at that time with us online, absolutely normal, just a vasovagal reaction. He said he felt better after a couple of minutes, so okay, fine, you can take a shower, I'm going to take lunch. And then before he took a shower he said, I don't know what it is, but there's something different and I don't trust it. Can I have another resting ECG? We then did that, and then we saw 2 millimeter elevation, and sent him to the hospital right away, where they cathed him, saw the obstructed LAD, thrombosuction, and stented him, and I think 2 hours later he was doing great again. So that was lucky for us. So we're doing really good on the screening, right? This is excellent job. Well, I'll come back to that later. Next slide, please. So we do this exercise ECG after we've had these accidents with a couple of colleagues, and started doing the exercise ECG for pilots when they're older than 40 years, once every 3 years, and over 50 years yearly. And also in suspected asymptomatic coronary artery disease or peripheral. And what you are allowed to have when you have a positive ECG and you then do a conventional coronary angiogram is highlighted in red. You are allowed to have so much stenosis. That's what we're looking for, which is basically, you know, if you have that, the end game of coronary artery disease, right? So no more than 50% of stenosis in any major untreated vessel, no more than 2 stenosis between 30 and 50 within the vascular tree, and the whole coronary vascular tree has to be assessed as satisfactory. And so you look at the whole picture, of course. You have to see significant stenosis. Next slide, please. And so far, we look at the data that we had. 263 subjects, predominantly male, aged between 40 and 55 years. All Framingham risk were low of everybody. 24 positive tests, and most of those tests were because of rhythm anomalies, which could indicate ischemia, and only about 7 of them had ST segment changes. And out of those segment changes, 3 turned out to have coronary artery disease and were treated. So we found 3, and is that good? Is that good enough? Next slide, please. If we look at a study, and I'm going to talk you through this a little bit, a Dutch study just published a couple of years ago, where they had 255 subjects, female and male, 54 years old, plus or minus 12, without known coronary artery disease. They did the exercise ECG, which turned out to be either normal or abnormal with that ST segment. And if you look at them, they did an MSCT. 155 of them, 61%, had coronary artery disease, of whom 78 had obstructive coronary artery disease. Now, if you take that obstructive coronary artery disease group, those 78, and you do those, and you look at their exercise ECG, only 46% of them were positive. That means 54% missed. That's quite a big group that we missed then, and that is, you know, in our Air Force perhaps still flying. And next slide, please. One more study to just get my point across, where they had 200 subjects doing an exercise ECG. 20% was positive, 80% was negative. Now, out of the positive, which was out of the 36, 15 turned out to be turn out to have obstructive MSCT. So a lot of false positive probably. But more importantly, I want to stress that if you look at the negative group, the 80% that you sent home and you tell them you're doing great, 27%, 38, had obstructive MSCT also, confirmed by coronary angiogram. And we're probably doing exactly the same in our center, where we have a couple of people that you send to the hospital, and a lot of people you send home, you're saying, you're doing great, you can fly single seat, high performance, or helicopter, or whatever. And you're actually, you know, we might have a couple of people that have a high risk. Next slide, please. So the exercise ECGs has some pros and cons. It's cheap, it's non-invasive, it doesn't use any radiation, and you also see some exercise-induced rhythm disturbances that might be ischemia or something else, which is a problem. On the other hand, it has very low sensitivity. Because of that, you have a lot of false positives, especially because you have a very low prevalence of disease. On all those false positives, you do unnecessary testing, and the people that are false positive also are labeled. Next slide, please. So the question is exercise ECG good enough? Then we look at what else have we got. Next slide, please. What we are using to really know what's going on, if we are in doubt, is the conventional angiogram. Here you see the conventional angiogram, and everybody can see the nice, you know, problem that we have there in the artery, and it's a very direct imaging of the lumen stenosis. So that seems to be the perfect technique, right? So let's look a little bit further. Next slide, please. It's the gold standard, and you can see, you know, direct imaging of the lumen narrowing. And if you give them adenosine, not caffeine, but adenosine, then you will see some vessel dilating, and the amount of dilation will tell you how much flow reserve he has. It is invasive. I know the Americans have done, I think, 960 or so without any problems, but with invasive you do have a risk, and you do also use a radiation dose. Next slide, please. Looking at all the other techniques that we have available, on top you see the exercise ECG. Of course, we already talked about the low sensitivity of 50% and a specificity if you use the 1 millimeter as a cutoff point, ST segment change, of 90%. Actually, the Central Military Hospital cardiologists have told me that their results are a lot worse than this if they compare it to MSCT and conventional angiogram. So it's not as good as the articles try to make me believe. The angiogram gold standard, we talked about that. The MSCT, if you know about the MSCT, you think this is quite high, 94%, 97%, right? Could this be right? Well, I'm using the most positive figures here, and I do that on purpose because I think our group is with a very asymptomatic group with a very low prevalence of disease, gives very little problems in looking at the MSCT, and because of that you will have a very positive sensitivity and specificity. Now with the low prevalence you will see that the negative predictive value is nearly 100%. What does that tell me, a negative predictive value? That tells me that if I say that the MSCT gives me the picture that you have no lumen narrowing, no significant stenosis, that you can be nearly 100% sure that it is true. So you can send them back to that plane, and you can be, you know, you can feel warm and fuzzy about that, instead of with the exercise ECG, where at least half of them go back home, and they are at high risk of having a heart attack in the near future. Half of the people that have the cardiac disease. The other tests are also have a lot of disadvantages, so I'm not going to go into detail about that now. All right, next slide, please. So looking into the multi-slice CT, this is the whole machine. You put somebody on there, and in between a heartbeat you make a CT scan. You have to make 2 of them. And the heart rate has to be low enough so that you have enough time to make the scan. So you try to get the heart rate below 60. If you can't do that, you give them a beta blocker. But most of our pilots can do without, do fine. Next slide, please. This is a picture of MSCT. Here you can also, just like the conventional angiogram, get a direct imaging of the stenosis. You will see the stenosis right there, and you'll also, if I can get this to work, I think the battery is about to die on me. Well, everybody can see the calcification, I think, that you see on there. Next slide, please. Another picture of it zoomed in a little bit. You see the artery where, again, there you can see the problem. And I think, I'm not a cardiologist, but I think there's some calcification and there's some non-calcified plaque that is shown, which gives you lumen narrowing. But you can also see that over here there's no lumen narrowing, but there might be wall thickening. That is important because we've already learned from our American cardiologists and British that on MSCT you can see the beginning of the disease, and that's the big change, I think, the big advantage also. What you can also do is, this picture is not that clear, so if you have a little bit doubt of whether you see a problem or not, you can scroll through the lumen, scroll through the artery and go as if you're a spaceship going through the artery. Perfect. Next slide, please. You can make a 3D picture. You can see vessel or artery anomalies on top of the lumen narrowing also. Next slide, please. So everybody understands this. You don't have to be a cardiologist anymore, or a radiologist. We can all look at this picture and understand what we're seeing. Next slide, please. So the MSCT has a high sensitivity and specificity, I think especially in our group, in our population, and is most important for us is the negative predictive value, because if I just have a handful of pilots that I'm not completely sure, then I'll do the rest of the investigation. That's not too bad. And nearly 100% is incredible to me. It's non-invasive, direct imaging. More important, I think this is a really big change for cardiology, for coronary screening. It's more than lumen measurement. It's also wall thickening prior to stenosis. That's what I would like to see, because the guy that has a significant stenosis, more than 50%, that's the end game of the disease. He's already at high risk. I would like to know the one that has less than 50% but also has a disease. I cannot show that, not always show that on conventional angiogram, and I cannot see it in exercise ECG, but he might be at high risk. The major group of people that have an acute myocardial infarct does not have a significant luminal narrowing. They are in the insignificant, the lower group. So I would like to see those as well, because what are we going to do with them? They're at high risk. They have an unstable plaque that might rupture, and they have an acute heart disease. You can distinguish between the plaque types, so I would like to see the difference. Is this a calcified plaque that is stable? Of course it's an indication of coronary artery disease, but before we have that, you might have an unstable plaque that is not very much lumen narrowing, but it is unstable and it's high risk. I would like to see possible evaluation of left ventricular volume, ejection fraction, regional wall motion. Also the computer can do it for you. It doesn't take much time, but you cannot see direct ischemia. Do I care? I don't know. Perhaps I don't care too much. It's clinically, it's very relevant. But for the pilot who is asymptomatic, that's end game. I would like to know before ischemia happens whether he's at risk. That's what I want to know. You don't see stress-induced arrhythmias. What the arrhythmia I want to see is when it's indicative of ischemia, and I would like to see again before that happens. It's hampered by severely calcified plaques and stents. because that causes partial volume artifacts, which in turn obscure the coronary lumen. Hopefully we don't have too many people who have that situation, so we probably can do very well with the MSCT. If it is possible, positive, the MSCT, if you have significant stenosis or you do see significant disease, of course you have to do conventional coronary angiogram then after that. And then another disadvantage of MSCT, for some countries more than for others, is the radiation dose. What do you do with the radiation dose? Now, quickly talk about that. Next slide, please. Radiation dose with the MSCT, we talk about the effective dose. It's not the same as total dose. It's computed by summing the absorbed doses in the organs weighted by their radiation sensitivity. So it's, it differs. If I'm a big guy, I need more radiation to look at my arteries than if I'm a very small, thin-built guy. And that's with the 256 MSCT, you have to do 2 scans, one for the calcium score and one also for the coronary CT. And the total effective dose is 2 to 3 millisievert. How do we put that in perspective? Take a look at the total natural radiation. Total natural radiation dose, 1.5 to 2 millisievert. If you're a pilot, you get a bit more. You're up high in the sky, unprotected. You get about 2 to 3 millisievert. So it's about the same. So everybody makes his own, judgment on how you perceive that problem. Next slide, please. So MSCT for coronary artery disease screening has some issues. Sensitivity, really good, I think. Negative predictive value, excellent. It's safe. There are some costs, but all the guys that you give an exercise ECG that are false positive and you put through echo and MSCT or coronary angiogram where it's not necessary, that's quite expensive as well. So perhaps it turns out to be in the same ballpark. What is the cost of a pilot who has a myocardial infarct in the air? That's quite a high cost as well. It's a small chance, I know. The radiation is an issue. You still have to do a coronary angiogram. Then what does a stenosis, what is the quantification of the stenosis compared to the conventional angiogram? It's very, very comparable. The experienced guys told me that there is some overestimation of the stenosis, but if that is a real problem, I don't know. I don't think so. Non-significant stenosis, what do you then do? What does it mean if you have a very small amount of stenosis? It's not significant like our rules, because our rules that we have are based on conventional angiogram, and actually now we know that there's a high-risk group out there that we'd like to consider, that we don't see on the conventional angiogram. So what are the consequences of non-significant stenosis? Do we follow up every year, every 5 years? What do we do? Do we give them treatment? Do we give them statins? Can they still fly high performance? Can they fly single seat helicopter? Can they fly at all? I don't know. So we have a lot of questions. Next slide, please. So the questions, we'd like to get through a study, which is collaboration between Centre of Man and Aviation, together with the Central Military Hospital in Utrecht, with the cardiologists that work for the Air Force. And I've been fortunate to be in the European Air Group Advanced Aeromedical Aeromedicine course. And I met the British cardiologist, and I talked to the American, and there seemed to be a lot of interest in participating. That would be very nice. That would be a good demonstration of international collaboration. The objectives: research the value of MSCT in asymptomatic flying population. How many people have a problem? What are we looking at? I have no idea. Nobody has a clue, because all the studies are with symptomatic older guys, and our 40 years old, 45 years old pilots. How are they doing? I have no idea. I would like to pick out the guys that are at high risk. Study the progression of the disease, and study the effects of intervention with, for instance, statins. and also try to find new biomarkers to support your MCT study. So that's for the study. Next slide, please. Any questions for me or for our Dutch cardiologist Rinkrings?
Just said you have more questions than answers. But what about the question, in which age do you want to start that, and do you want to make it then each year even if there's no findings?
Good question. The question is, who are you going to give an MSCT and how often do you want to do it, right? Well, we propose in Holland to do the same as with the exercise ECG. So over 40 years we'd like to do it. And how often do we have to do it? I do not know yet. You know, is it once every 5 years? Is it once every 3 years? I do think that other countries might want to have a different interval or a different. You can have a different selection of the population. Perhaps they say we only want to participate with those pilots that have an abnormal exercise ECG. So you have an indication, because we cannot do it without indication. So we still have to work out the details in what way we can collaborate. Does that answer your question? Thank you. Any other questions? Okay, thank you very much. Thank you all.
Okay, so let's get. Wow, you're good. So what is your answer now? Coronary multi-slice CT is ethically acceptable for screening purposes with flying personnel. Ooh. Wow, that's a big change.